Alright, so we're looking at the pathology of hyperpituitarism. Hyperpituitarism, okay, pituitarism, and pituitary adenoma. So these conditions, they literally come side by side, they literally come side by side. So hyperpituitarism shows that the pituitary gland is basically functioning too much. So it's usually caused due to what? Presence of an adenoma, arising in the anterior lobe of the pituitary gland. So less common causes can be hyperplasia, carcinoma, ectopic hormone production, then some hypothalamic disorders, but those ones are less common, So pathogenesis of pituitary adenoma, which is the most common cause now, usually mutations in the G proteins, that's alpha unit, in the GNAS gene on the chromosome 20q13, leading to activation. Alright, so 40% are growth hormone products secreting adenomas, and less produce adrenocorticotropic hormone. So most of them produce growth hormone. So G proteins involved in a single signal transduction, and this is how the G proteins are usually involved in all of this. Mutations in alpha subunits interfere with GTPase function. Mutations in RAS, there's overexpression in C micro-oncogene and the NM323. Inactivation found in more aggressive tumors. So other mutations can have the main gene mutation, causing all those main syndrome, multiple endocrine neoplasia. So this is another interaction. This is histology of it. So features common in pituitary adenomas is 10% of them are all intracranial neoplasms, 25% incidental, 3% is due to main syndrome. Usually occur in 30 to 50 years of age. So primary pituitary adenomas are usually benign, may or may not be functional. If functional, the clinical effects are secondary to the hormone produced. So more than one hormone may be produced by the same cell. Then, although most are localized, invasive adenomas erode cellar tussica, extend into the cavernous sinus and the sphenoid sinus. Can you see how it's getting so large? So clinical features of pituitary adenomas. So symptoms of the hormone produced. Local mass effect is what? Radiological changes, visual field defects, elevated intracranial pressure, because it can get so large and compress a lot of things. Then sometimes the pituitary gland initially is functioning too much, but later on now the function drops. The pituitary apoplexy. Can I see this? This is a mass. So morphology is well circumscribed, invasive, just up to 30%. Size is usually 1 centimeter or more, especially in non-functioning tumors. Hemorrhage or necrosis in large tumors. Microscopic pictures is what? Uniform cells, right? Absent reticular network, rare or absent mitosis.